Hello, everybody. Today's session is going to be with Dr. Harold Van Bosse. He's from St. Louis. A lot of you may know him, but if you haven't gotten a chance to meet him, make sure you come up and talk to him either after this if there's time, or if not in the hallway or dinner tonight or sometime during the conference. He's very well known and well loved throughout the AMC community, so we're always glad to have him here. And he also serves on our board of directors. And today he's going to talk about AMC and scoliosis.
Thank you very much. All right. So let's talk a little bit about scoliosis and arthrogryposis. So it's a common finding in arthrogryposis. The literature says it's anywhere from 1 out of 5 kids to 2/3 of kids. In my practice, when I went over my own numbers, we found that about 22% of the kids that I was following had some form of scoliosis, and that was looking at, we had 760 cases of arthrogryposis and 117 with scoliosis. We find that there's a high prevalence in a couple of diagnoses. One is Escobar syndrome, that's the kids who have webbing pterygium, and the other one is Friedman-Sheldon syndrome, which is one of the distal arthrogryposes. Most of the curves present before 5 years of age. Some of these are actually present at birth. We'll talk about that a little bit. And then there are other curves that happen more like typical curves do later in adolescence, but it seems that most of them happen early on. So just setting a couple of quick definitions here. Scoliosis is any kind of a curve when you're looking at somebody from behind. A typical person should have almost an arrow straight spine. So any deviation to one side or the other is scoliosis. And then when we look at somebody from the side, we should all have a curve in our upper back and a small of our lower back. The upper curve is called a kyphosis. The lower curve is called a lordosis. And then you can place them all over the place. You can have hyperkyphosis if you have a very curved upper back. You can have hyperlordosis where you've got too much curve in your lower back. You can actually straighten out your kyphosis and it becomes a hypokyphosis. So you can do all kinds of word games with this. But that at least kind of sets the ground for some of the terms we're going to use here. So let's talk a little bit about, just so we have an idea of why scoliosis even needs to be treated. And really it's more for looking at the person when they're done growing. If when you're done growing you have a curve that is 40 degrees or less, that curve is most likely not going to progress. 95% of the time it's going to stay where it is. If you have a curve that's over 50 degrees, 95% of the time that curve will get worse during adulthood. And then between the two, between 40 and 50 is kind of a gray zone. So we watch these curves very carefully to see what they're going to do. Now, what about smaller curves? Well, curves under 20 or 25 degrees, we really just kind of watch those. We don't worry about doing any kind of casting or bracing until it's at least 20 degrees. And then depending upon the age of the child, maybe 20, maybe 25 degrees for treating it. And from what we were talking about before, the size of the curve of maturity, surgery is indicated somewhere between a curve over 40 degrees to a curve over 50 degrees. And so what else is important here? Well, we want to make sure that people are comfortable standing and sitting. If you have a large curve and it's throwing off your balance, well, that's also not very good in terms of function. Or worse yet, if you can't sit comfortably. There's a certain side of cosmetics. You want a cosmesis. People want to feel good about themselves and how they look. But the bigger things from the medical standpoint are cardiopulmonary compromise. Cardio means heart, pulmonary means lungs, breathing. And we want to make sure that we don't have a curve that's so big it's going to start influencing those. And we see on this picture here, we look at those two lung sizes there. They look very different. This lung looks kind of squat. Looks like it's a little bit squished together from top to bottom. And this one looks a little bit drawn out in a little pancake. It's kind of narrower from side to side. We start talking about something called pulmonary insufficiency. Typically, our lungs are built in such a way that we are maximally able to take the air that we breathe, have it go across a membrane where there's blood on the other side of that membrane so that oxygen can go from the air side to the blood side. You get an exchange of oxygen, and that's how we all stay alive. When we start messing with the shape of the lungs, we start to take those two processes away from each other. Or maybe we make it that parts of the lung are not getting enough air to them, and so the blood flows through without picking up oxygen. And that's a big, big concern. And over time, what happens is as you get more and more of a lung deformity, the heart has to work harder to push blood through. You start getting kind of a hypertension within the lung. The heart works really hard to push the blood through. And where the first does to respond is like any other muscle, it gets bigger and bigger because it's working out harder. But then it gets to the point where it's now starting to fail, and it's something called cor pulmonale. Now, those are all really scary concepts. Luckily, they don't happen until the curve is pretty big, 80 or 90 degrees. But even smaller than that, curves that are 60 degrees or greater, if you know how to test for it, you can already find that there's differences in how somebody's breathing and may also have an effect on their endurance for doing activities. But here we see a little bit about that chest deformity that we're talking about and how it's affecting the lungs. Here again, we have a squat lung here. We got a narrow lung here. And here also, this is the spinal column here. It's rotated, and we're going to talk about that a little bit later. But here we have the lung tissue here looks pretty healthy, but here we have somewhat healthy lung tissue here, but this whole area here, this is lung back here, but it's no longer functioning because you can't get air back there. And because you can't get air back there, you can't exchange that. So what are the different ways that we talk about scoliosis? Well, we typically talk about scoliosis in terms of the age that the curve started. So infantile scoliosis are curves that are first discovered someplace between birth and 3 years of age. A lot of these can be related to what's called hypotonia. That means that somebody doesn't have enough strength to hold themselves upright, so they kind of collapse down, and that's kind of the jump start to the curve there. These curves can either be, if they're nice and flexible, you can hold them out well, but in other cases, they can actually just take off terribly. Then we have this middle range, 3 to 10 years of age, or about 3 years until puberty. Not a lot of curves start during this age. It's fairly uncommon to see that. And then the second age range that we worry about is adolescence. As kids get to their growth spurts, the curves can sometimes take off. There's a certain kind of curve that does not show up very much in arthrogryposis, but worth mentioning here, something called a congenital scoliosis. And these are where the vertebrae are actually malformed. So instead of the vertebrae being nice little blocks, they're kind of triangular shaped, so that the spinal cord kind of takes a little bit of a deviation as it goes through that triangle. But again, not something we see very much in arthrogryposis. What we do see, though, are babies who were born with curves. And we had a hard time giving them a good term. So now the term we use is a prenatal curve. It's not a congenital curve. Yes, they're born with this, but a congenital curve means you have vertebrae that are malformed. This is a curve at 2 months old. You can see he's got this nice big curve here, and this is the way he was inside his mother's uterus. That's his positioning. As he goes on, he's holding that same position. Here he's actually able to get up on his knees, still has the same position. Now, what was nice is that he held that for a period of time without bracing or anything else until he got too close to adolescence, and the curve started to take off on us. And ultimately, we had to do surgery on it to be able to keep him in a good position. This is another kind of prenatal curve. This is luckily much less common, but it is in part cervical hyperextension. So cervical means your neck. Hyperextension is that the neck's all the way upright. A couple of things about that. One is that if it's diagnosed during pregnancy, there has to be great care in delivering the child so as not to get any kind of spinal cord injury. But the other thing is that it oftentimes goes along with this complete kind of a C shape here where the whole spine is in this position. And that can be very challenging to kind of gradually straighten out. As we did here, we try to have this big bump over here that we gradually would make bigger and bigger and try to straighten the child out over time. All right, so let's go back and talk about the infantile curves. These are the ones that develop between birth and 3 years of age. So here's the 13-month-old child who's got Escobar syndrome. That's the ones with the winging or the pterygium of their joints. We see that it's slowly progressing, or actually rapidly progressing from 13 to 17 months. Here's at 2.5 years of age, and it's at 3.5 years of age. So it's a curve that's getting worse quickly. Now, the one lucky thing about this is that the curve is sitting a little bit lower in the child's body, so the lungs have a little better chance of becoming symmetrical, but it's still still a pretty big curve. So this is one that we're going to have to do something about in a surgical way sooner so that we can allow the child to keep on growing without this curve getting worse and really affecting their chest. And the adolescent side, here's a 7-year-old girl with an 18-degree curve, and we started bracing. The curve slowly got bigger, but we were able to kind of keep it in control a fair amount. And then here she is at skeletal maturity, curve right under 50 degrees, and she's actually held there, so we watch her very carefully. What are the treatment options for kids with scoliosis who have arthrogryposis? There's not a lot of literature in there when we go to the journals. So it's a little bit difficult to draw conclusions. What I'm talking about here is accumulated experience, both mine and from colleagues of mine that we've shared cases with. But different things we can do. First of all, physical therapy. Now that's kind of universal for kids with arthrogryposis. We want to keep them flexible and as strong as possible. In the young kids, we sometimes actually have to try to correct their curves with casting them. So we'll talk about that in a second. Bracing is also fundamental for treating the spine curves in kids with arthrogryposis. And then we have a couple of surgical things to talk about. One is for the younger child who we can't hold them in a brace anymore, we have to move on to something else. We'll move on to expandable implants, a way that we can put some hardware next to their spine that we can grow up with them. And then there is the fusions. Should have done that. Then there is the fusions that we have to talk about for the really big curves. So start with physical therapy. Main thing about physical therapy, we want to work on trunk strengthening, especially asymmetric exercise. If you got a curve up to your right, we want to try to strengthen those right-sided muscles so that you can keep your back as flexible as possible. Sensory integration, so you have a feeling of where your body is in space. When you're sitting upright, you know what upright is. Prone exercises. For the little kids, I like having them do a lot of lying on their belly so that they're trying to get their head up and looking around them, and that strengthens their back extensors. And the low-toned babies, those kids who are very weak-muscled, when they are little babies, I don't want parents to sit them up. Now, all of us who have had babies, you love to sit them up. It's kind of a fun thing to do. But the kids who are very low-toned, when you sit them up, they collapse down. And if they keep collapsing down the same way, that can kickstart a curve. So what we try to do is to keep them down as long as possible. So instead of sitting them up, we like to have them leaning back in like a high chair at leaning back about 30 degrees or so. So they can still see the world, they can still interact, they're working on their neck strengthening, but they're not unsupported and collapsing down. When the kids have a big enough curve and they're young, then we start talking about doing spine casting. I like to talk about spine casting as being an old technique that was reborn. Back before I started my training, when a teenager had a big curve, what they would actually do is put casts on them over a stretch of several weeks, each time trying to straighten them out a little bit more until they got them as straight as possible, and then they would take them to the operating room, make a big groove in the cast, operate through that. They didn't have any rods at the time to put in, so just operate through that, scrape up all the vertebrae, put down bone grafts to simulate healing of one vertebrae to the next, and close things up and leave that same cast on. And that was how you try to manage the curve as best as possible. So about 20-some years ago, there was a young lady, or a physician from England who came up with the idea of using the same technique for children, trying to use that to help straighten out their curves when they're quite young. And for the longest time, we said this is only right for kids under 3, and now we've kind of been loosening up the ideas up to even 6 or 7 years of age works out well. You do this under anesthesia. The different casting schedules, if we have a child who's under 2 years of age, we cast them every 2 months. Between 2 and 3 years of age, we change it every 3 months. And over 3 years of age, we change the cast every 4 months. And we finish either when we got the curve corrected or we've reached some kind of a plateau, and then we go into a brace. So part of what we're doing is trying to untwist the curve. Remember, I showed you that other image before, and I said, well, the spine is rotated. So if you're looking here, this child here is bending over. We call this the Adams forward bending test. You can see that the ribs are a little bit higher on her right side than on her left side. And what's happening is that when the curve starts, you first get this rotation of the spinal column where the curve is. And that kicks up some curves backwards, some ribs backwards, and it kicks other ribs more forward. So the chest actually kind of shifts a little bit when that happens. So in casting and also in bracing, part of what we're trying to do is not just the side-to-side correction, but also the untwisting of the spine. And that's what we try to do when we put a cast on. So this is a child getting their cast put on the table here, and you have what we call head halter traction. Does this work? No? Okay. We have head halter traction here, kind of a thing comes underneath the chin and behind the head. And we also have pelvis traction here, and we pull between those two. So this child is actually suspended just in a bar here and a bar there, and the traction going across. And this gives us the ability to go all the way around their body as we're putting on the cast, kind of like you see here, and then molding the cast, trying to untwist the spine over here as we're actually pushing from side to side as well. And so this is what our table looks like. And again, usually it's for curves that are over 25 degrees. We need general anesthesia. We talk about the head halter traction. And this is us putting on a cast. You can see how we can come around the body as we're casting there. Here we're molding, cutting out the windows in the cast, and then overlapping with a nice color. And so we looked back at 14 kiddos with arthrogryposis we had casted over a span of time, looking at those that we had some follow-up on. And we looked at what the curve size was before we casted, what it was when we do color traction release film, gives us an idea of how flexible the curves are. Essentially, we pull on the arms and legs and let them go, and then take an x-ray while they're asleep. And that gives us an idea of how flexible that curve is. And then we would get x-rays in cast, as well as x-rays when they came out of the cast, and see how they did with that. And we changed the cast, like I said, every 2 to 4 months. I'm going to go through this. There's a lot of stuff that I'd be happy to talk about to somebody later on if they're interested, but in essence, just looking at different parameters that gives us an idea of how big the curve is. Or here, this is a way of measuring what the difference in the lung shapes are. Again, we're trying to get very symmetrical lung shapes. This is that, again, that one we were just talking about, the space available for lung, which we just look at the height of the lung from the top down to the diaphragm on both sides. And I'm going to just go through this a little bit. So it'll look like exciting stuff when I put it in here, and I'm like, probably not that exciting. So then we would try to come up with different endpoints. So one endpoint is the cured curve. This is where we can take a curve down to under 25 degrees. Remember we said we start treating at about 20 or 25 degrees. So if we can get that curve down below that, say about 15 degrees or so, well, that's a great place to be. Put the child in the brace for a year, and then after that, then go without a brace. So that's really the high point of success for us. The next point is a braced curve. This is one where we can't get them down that far, but at least we're able to keep the curve in control, let them keep growing, and hopefully hold off for the future to do something else. And then there's the controlled curve. These are ones where we know, even before we start casting, that the curve is going to need surgery at some time. And all we're trying to do is delay that sometime as long as possible, hopefully getting it past 5 years of age. So why 5 years of age? The things that we'll talk about in a little bit, the expandable implants, they have a lifespan of about 5 years, meaning from the time you put them in, you can only stretch the spine out for about 5 years, because what's happening in the meantime is the spine is starting to stiffen itself up. You pull on it a little bit, and you're starting to create a little bit of arthritis between the joints, not the painful kind of arthritis, but the type that stops joints from moving. And over time, you get an autofusion. The spine just becomes one block of bone. So if you start that at, say, 3 years of age, you get to 8 years of age, and then we can't do anything because the child is still growing. Therefore, if we wait until 5 years of age, we get to 10 years of age, that's not a bad place to end up growing. But it'd be even better if we start at 7 years of age, get them to 12. Then they've had a lot of growth, they've got a lot of chest height, and that'd be a perfect time to be able to do it. So here's some examples. This is what it looks like Before we cast it, here's in the cast, this is the cast looks like, this is the back of the cast looks like. And what we found from ours is that the average age that we started was about a little over 2 years of age. On average, our kiddos had about 9 casts, but can be anywhere from 4 to 20 casts. Time in the cast was on average about 3 years that each child was in there. If we looked at the average pre-cast size, it was about 51 degrees, and at the end, it was 52 degrees out of 51 degrees. So we really got very little change. And in comparison to a lot of other conditions that we treat, this is not very exciting results. You're keeping them steady. Now, the other point I'll make, though, is that that 50-degree mark is typically where we would talk about surgery. Remember, closer to the beginning of our talk. So we were able to stop that curve from getting bigger for, on average 3 years, let them get a lot more growth before we had to move on to whatever the next thing was. So here's the one cured curve I had. A child with Sheldon-Hall syndrome, 28 months of age, had a 40-degree curve, which is a very significant curve at that age. But at 2.5 years later, 5 casts, he's got a 22-degree curve. So we actually were able to treat him without a brace for several years, and now slowly he is about 10 or 12, and that curve is slowly coming back. We've got him back in braces. But we were able to get a number of years that he had nothing at all that he needed for his back. Here's a 2.5-year-old. She started off the 64-degree curve. That's a very sizable curve. But we were able to cast her for about 3.5 years, get that curve down a substantial amount, and we're able to then treat her with a brace, and she's still in brace. And then this is a controlled curve. So it's an 84-degree curve. That's one that we know we're going to have to do surgery on. That's way above 50 degrees. There's no way we're going to be able to make that much smaller. But we were able to at least keep it in the 80-degree range for several years before we went on to having to do something surgical, which in this case was this expandable rod. Another curve like that, 71-degree curve, brought down to about 50 degrees. And in the end, that curve just got away from us and had to have, again, the same kind of surgery done. So I'm just going to move through this part. This is just a lot of results. But so what we're looking for then is to have the cured curves, bring them down as much as we can, but short of that, if we can modulate the curve, so we can allow that child to do a lot of growing without the curve getting much bigger, trying to keep the lungs fields as equal as possible, then we're really doing the best that we can. So what about bracing? Well, bracing is for curves that are bigger than 20 or 25 degrees in a child that's not really appropriate for casting. And usually what I mean by that is that they're old enough that casting is not something we want to do. Now, the difference between casting and bracing is that a brace can't make a curve smaller, whereas in some cases a cast can make the curve smaller. So this is kind of what it looks like, a child out of brace on the left and brace on the right, and we're seeing we're kind of pushing them up, holding them up a little bit. And there's some x-rays of her in and out of her brace. You can see that not only are helping her with the curve, we're also helping her some with her kyphosis here. And then here again, just a little travel log. 2.5 years old, child had a 40-degree curve. We're able to hold it down at 30 degrees in the brace, and we're able to get another 3.5 years out of her. The curve slowly progressing, but at least we got her to grow a lot more before we had to do anything surgically. Here's a 7-year-old, child with Escobar syndrome. He's got a curve in the 50s. That's him in his brace. And we got another 4 years out of him before the curve really got quite big. But at this point in time, he's 11 years of age. Now we can go ahead and just do a straight-out fusion and get him straighter and better balanced. So in terms of the surgical options, really what we have is trying to keep up with the growth of the spine with an expandable implant, or when someone's done growing, just fusing the spine, getting it straightened out as best as possible, and making it into a solid bone. In the past, we didn't have that ability of doing the expandable implant, so people were doing fusions for the infantile spine. You would get a very nice result in the operating room. The problem is, if you operate on a 6-year-old and you straightened out their spine and fused it, Then when they got to be an adult, they'd be an adult with a 6-year-old sized chest. And now you don't have enough room for the lungs, and that person has a hard time, those lungs have a hard time supporting the person. And this is a serious issue in terms of staying healthy as an adult. So that's when the expandable implants came around. The first types of expandable implants were actually ones where we would have hardware that would be kind of a rod coming from above, a rod coming from below. They would cross each other. You have some kind of connector, and every 6 months we go to the operating room, loosen that connector, and stretch them out a little bit and tighten up the connector and wait for another 6 months. And that worked out very well, except for twice a year going to the operating room. So that's when it was nice that they came up with the other kinds that are, so this is an example of that. We've got the little cross connector here. And this is just another form of kind of the same thing where you have a little cross connector there. But then they came up with this type here. This is a magnetically actuated rod. So you see some clear spots here. This is where a telescopic rod has already done some lengthening. This thicker region here and up there, there's a little magnet that sits in there. And as that magnet spins, then it allows for elongation of the rod through a telescopic rod. And the way you get that magnet to spin is with an external magnet you put on there. It's got a couple of really big magnets. They rotate, and by rotating, they make the little magnet inside the rod turn. So that's worked out very well. We can do that in the clinic. We do that instead of twice a year, we do it 4 times a year, so it's a little more gentle on the spine. Now, unfortunately, it is not perfect. So the magnetic rods can only create so much power. It's about 40 pounds of pressure they can create. And as the curve gets stiffer and stiffer, they're unable to do much pushing against it. So it certainly has a lot of upsides, but it does have a few downsides. And this is that piece of equipment we're talking about, the external magnet that we use to lengthen the rod with. So we have this boy here, 5-year-old boy, 103-degree curve. We tried to cast him for a bit. We got him to 5, but then we had to do something else. But that's when we put the magic rods in them. And you can see from this picture to that picture, you got these much bigger areas here that are clear, and that's because that's how far we've been able to distract out the rods and get them somewhat taller. Where's my last picture? Let's see. So we got him to 12 years of age, and the curve is about 50 degrees. And the lungs are not perfectly symmetrical, but they're a lot better than they were. So we did pretty well with that. Here again, we looked at the kids that we had. We only had 7 children with arthrogryposis that we could look at. But kind of the main thing to say here is that we were able to keep most of the curves fairly well in control. And looking at how much we were able to grow them up from the bottom of their neck down to their pelvis. So we were able to get the curves from 82 degrees before surgery to 53 degrees down the road. Kyphosis is how much forward they went. I got 15 minutes left. Okay. How much forward they went. That worked out pretty well. We kept that in a reasonable range there. And the space available for lung, able to make that a little bit better. So you want this number to be 1.0. That means both lungs are the same size. Here we went from 0.74 to 0.86. So that meant that we got a little bit of a better improvement. The other thing to look at here is that before we started, we had only about 26 centimeters of height, and that came up to about 30 centimeters of height over the time of lengthening. It's not a huge amount, but it does kind of keep up a little bit with the growth. So here's another example here. This is a child, 5.5-year-old child, had an 80-degree scoliosis and also an 80-degree kyphosis. So not just a bad side-to-side curve, but as you're seeing here, also a very big curve in the top of the spine. And the problem with that is that we can't put a rod on either side of the spine. The spine is very prominent over here, so we can't lay a rod there. So instead, we just lay a single rod on one side, and you try to use that a little bit like a car jack. If this is the curve, we put the rod here, we're just trying to jack up the curve slowly like that. And we're able to get a fair amount of lengthening through that. But again, just a very big and very difficult curve to work with. And here's a similar case. More of that. Sometimes we put these talks together, you think you have some really exciting stuff to talk about, and you get to it and you go, we'll just move over this. Okay, so what about how far do we treat them? One of the things that we were talking about before is how much pressure you can generate with these rods. And the reason why it gets harder and harder to expand them out is because we said that the spine starts to automatically fuse itself up. So oftentimes you get to a point where you just can't lengthen out the rods anymore. From my perspective, that means that I've already got enough of a fusion there that I don't necessarily need to go back in and do an outright fusion. If the child is pretty well aligned, their head is nicely over the shoulders, which is over their pelvis, both from front back as well from side to side, then I'm happy to leave them with the shape of back they have. And instead of doing a big operation to fuse everything, I'd rather just make a little incision at the top and at the bottom, undo those screws, pull these rods out, and put some solid rods in there to hold the same position and just tighten that all up. Why do you have to take these rods out? Well, there's all these little mechanical parts here that they will keep on feeling a little bit of a movement over time, and then you start getting some metal debris and metal wear, which isn't a good thing. So the manufacturer likes us to take these out. But that's what we did here. So we took these rods out and just put the two solid rods in there, and then that is the end of our treatment. So, these are really small series of patients to talk about. The magnetically expandable rods really work very nicely. And again, want to delay that first surgery to about 5 to 7 years. In the very big curves, we use just one rod on one side. But those are very challenging curves anyway. All right. Now let's get to surgical fusion. And we're still, got 10 minutes to do that. So the whole idea of the surgical fusion is somebody who we've now gotten pretty close to done growing. We want to get the spine into a nice position, and we want to roughen up all the vertebrae to make them think they've been fractured. Then they heal one to the next, to the next, to the next, and you get up with a solid bone. And to align them, you use a couple of rods, one on each side of the spine, and they're anchored to the spine with screws, sometimes wires, sometimes hooks, to keep that alignment there. And I like to tell patients that, after a year or so, you have a solid bone, you don't need the metal anymore. We don't take it out because it's a very big operation to take it out, but we could if we needed to. So here, for example, a 16-year-old, it's got a good-sized curve, but the other thing this patient has is a lot of pelvic obliquity. So instead of their pelvis sitting level, they're sitting like this, so they're really only sitting on one butt cheek, and that's very uncomfortable and difficult to balance in your wheelchair. So then this fusion here goes all the way from the very top down to the very bottom into the pelvis, and we're able to now flatten out the pelvis better and allow them to sit nicely and prevent this curve from progressing in the adulthood. So there's a lot that's unknown. There's still a lot of research that we need to do to understand better when to intervene on these curves, how we can lessen the curves, and how we can get by with less surgery. And we really need big studies to do that. So that's where we try to do different multi-center studies where we pull people together from different institutions to collect their patients and discuss them together. There's just a couple of different papers we were involved in. This is one on Escobar. Escobar, like I said at the beginning of the talk, two very challenging conditions with scoliosis. One is Escobar syndrome. The other one is Freeman-Sheldon syndrome. They just have very difficult curves that are very hard to treat. And I think that is actually part of the talk we should have gone out. Okay. So what I'd rather do right now is answer any questions. Thank you.